Good evening, everyone, and welcome to the Victorian Newborn Screening Forum for Galactosaemia. My name is Rhonda Greaves, and I'm the Deputy Head of the Newborn Screening Laboratory. I'd like to start tonight's proceedings by acknowledging country and the Wurundjeri people of the Kulin Nation on behalf of VCGS, the Victorian Clinical Genetics Services. And I'd like to take a moment to acknowledge the Aboriginal and Torres Strait Islander people as the traditional custodians of the lands on which we inhabit, and on behalf of all speakers, pay our respects to the elders past, present and emerging. I'd also like to acknowledge the Victorian Department of Health, who are fundamental to running this program, and we work very closely with them for the success and the quality of the program delivery. And this program for Victoria is fully funded by the Department of Health and has been for now over 58 years. And this is a really exciting time because, as you can see, back in 1966, we actually started with PKU, phenylketonuria, and we've added conditions over the years. And as of the start of this year, we have screened over 3.7 million Victorian babies. And this really has to be the greatest success for a public health program. It's really looking after our next generation. Now, you can see on our slides that we have a number of conditions that we've implemented in recent years, and it's really got quite busy. And tonight we're here to really talk about galactosemia screening. Now, part of the reason why it has become a little bit more busy is some work by the national government on a national policy framework that was developed in the late teens of 2000 to give a more consistent and harmonised approach. And more recently, the federal government has actually really looked closely at what states have been screening and each jurisdiction. And here is an extract from the Department of Health website, and I have the website, and you can look at what's coming for newborn screening, and you can see a number of conditions, and there's 32 on this count. That includes galactosemia. And just highlighting this for you, it says that Victoria has commenced a pilot for galactosemia, which we did earlier this year, and we are still running in pilot mode, and that it is consistent, it will be consistent and is consistent now across all of Australia and New Zealand. So this is really a fantastic step for harmonisation, and that it means every baby, whichever jurisdiction they're in, will have all these same tests. So with this, we really have a wonderful opportunity to actually continue to advance the program. And we are looking towards the future, but as I said, this evening is about galactosemia and talking about that. Now, to implement a new condition, there are a lot of steps, and this 7-step cycle is actually showing all the things that we have done. And we are still in background mode because the last step of accreditation, which is our little red dot here, is still outstanding. We did submit a few months ago, but we are still waiting on that accreditation component. And that is why we're running in background rather than live when we're saying reporting to the maternity service providers. We are still reporting to our clinical teams for any abnormal results. So it's just a regulatory step that we're waiting to jump, and this should happen quite soon, either in the next few weeks or in the new year. So this evening is about galactosemia, as I said, and we have an aim of this forum for maternity service providers to better understand galactosemia screening and to be able to discuss it with new mothers of babies, and to be able to discuss some of the changes in the newborn blood spot screening card that we've undertaken as a result of galactosemia, and explain changes in reporting that will come through as after our accreditation. Now, to do this, I've already introduced myself as with the introduction and chair. We have two fantastic speakers. The first one is Dr. Tali Minto, who's going to talk about galactosemia and a clinical overview. And Tali is from the Metabolic Medicines Unit, a department at the Royal Children's Hospital. She's completed her training in general paediatrics and metabolic medicine and clinical genetics in Queensland. And having worked interstate, she has experience with newborn screening for galactosemia. And she's going to give you a fantastic overview of galactosemia that we hope you take away with you as part of your learning. And our next speaker is Dr. Mercy Thomas, who is a researcher and educator at VCGS. She is a highly accomplished registered nurse with a distinguished career in clinical practice, project management, quality improvement, and education. Her diverse experience spans acute, subacute, and educational settings, offering a well-rounded perspective on healthcare delivery. We're very lucky to have both of these presenters here. Towards the end of this hour, we're going to go to our traditional question and answer panel discussion. And we're inviting our brand new educator. Holly has been with us for a month, Holly McNamara, to join us for this panel discussion. Now, there is a question and answer button, so you can ask questions during the presentations, and we'll do our best to answer them during this. And if we can't, we'll try and get back to you later. So now I'd really like to hand over to Dr. Tali Minto, and so we can listen to her wonderful presentation. Thank you for joining.
Thank you very much. So as I mentioned, my name's Tali, and I thought I'd give you a quick overview of the clinical aspects of galactosemia and what we're sort of thinking about in terms of the condition itself and how newborn screening fits into how we would diagnose and manage these children. But just briefly, an outline of what I'm going to talk about, which is galactosemia as a diagnosis and a medical condition, focusing particularly on a form of galactosemia called classical galactosemia, and I briefly chat about the clinical features of galactosemia and the management, and show you a couple of case studies and how newborn screening fits into diagnosing these children as early as possible to provide them with the best possible long-term outcomes. So galactosemia is a rare inborn errors of metabolism, and inborn errors of metabolisms are defects in cellular pathways in the body that are important for energy generation or cellular metabolism. They're all genetic conditions, so babies are born with these conditions, and they're fairly rare individually. So classical galactosemia affects about 1 in 50,000 babies in Australia, although there are higher rates in different countries around the world, such as Ireland, where it's about 1 in 15,000. And this equates to about 1 to 2 babies a year in Victoria that we'd expect to pick up. And the reason that we think it's a very good candidate for newborn screening is because galactosemia can have life-threatening complications if not identified and treated promptly. So just to give you a bit of a brief overview, galactosemia is a condition caused by a defect in the breakdown of galactose. And galactose is a milk sugar that is present in all mammalian milk. So that includes cow, sheep, goat, any of your sort of more uncommon milks, as well as human breast milk. And lactose, which is sort of the predominant sugar in milk, is broken down by the lactase enzyme to produce galactose and glucose. And most lactose-free formulas that are based on dairy milk out there actually just have lactase introduced, so they still contain galactose. So I promise not to completely overwhelm you with pathways, but this is just a bit of a brief overview of how the body breaks down galactose. So we start with lactose, and then we have galactose. There's 2 forms of galactose which can be interconverted using a enzyme called galactometeorotase, and then we change galactose into galactose 1-phosphate using the galactokinase enzyme, and then into UDP galactose, another form of galactose using the galactouryl transferase enzyme, and then we recycle some of those components using something called the UDP epimerase or epimerase enzyme. And the reason it's important to know about these is that each of these enzymes can have faults, and all of these will result in a form of galactosemia that we would be able to pick up by newborn screening. So the most common form, or galactosemia type 1, also known as classical galactosemia, which will be most of the focus of this talk, is if we have a defect in the GALT enzyme, but we can also have defects in the galactokinase enzyme, the epimerase enzyme, or the galactose mutaroatase enzyme. And so, as I mentioned, there's these 4 different types depending on which enzyme is affected, and they're all relatively rare, but classical galactosemia is both the most severe and the most common. And that was sort of is the primary focus of this newborn screening program. The clinical features of the other forms of galactosemia tend to overlap somewhat with classical galactosemia, but often are not quite as severe. So if we look now specifically at classical galactosemia, again, this is following the same pathway, conversion of lactose to galactose and then Gal1P. And normally then we get further down this pathway, but if we have a defect in the GALT enzyme, we actually have a block at this step. So rather than getting to our UDP galactose at the end, we have accumulation of this galactose 1-phosphate, and then the whole system sort of backs up. So we get back increases in the level of galactose total, as well as using some alternative metabolic pathways to try and fix this block, I guess, and get rid of galactose. So we end up with accumulation of other chemicals in the body as well. And the problem with that is that all of these, when they accumulate, are actually toxic. So classical galactosemia is deficiency of that GALT enzyme. We get the accumulation of those galactose and other chemicals in blood and body tissues, and that actually impairs the organ function of those tissues. And so we can see a multi-system disease that presents. And just a bit about the clinical features. These babies, often when they're born, are completely well, and then over the next few days to weeks, they might develop some fairly non-specific clinical signs. The most common sign in infancy is actually jaundice, but there's also vomiting is not uncommon. These babies often have failure to thrive or weight loss because they're simply not able to use the milk to provide the energy the same way that other babies might be. Poor feeding, lethargy, and diarrhea are common. And the challenges with this is that jaundice, vomiting, and weight loss are very common in the newborn period, and certainly that most people's first thought wouldn't be galactosemia. So it's quite difficult to separate out clinically these babies who might go on to become very unwell from the babies that might have a less severe condition. However, as time goes on, these babies tend to declare themselves. So that organ impairment develops, particularly in the liver. They will get an enlarged liver. The liver starts to fail, so they doesn't make appropriate clotting factors. There's significant liver dysfunction as well. As the body tries to excrete these accumulated chemicals, you get kidney damage, an increased urine output. The brain can swell, so the fontanelle might feel full or bulging, which is terrifying to most people who examine babies. There's a very specific eye finding known as oil drop cataracts and can occur fairly commonly. And the thing that can be fatal in some cases is that a high proportion of these babies develop sepsis, and they seem to be particularly susceptible to E. coli sepsis. Assuming that we diagnose them early and they survive the newborn period and are managed well, they go on to have a number of features in childhood. Bit of mild growth impairment is common. Speech and language difficulties are particularly common. About 2/3 of these children, no matter how well we manage them, develop some speech and language difficulties, so that has to be monitored very carefully, and the mechanism of that is not fully understood. Particularly children who've been very unwell in the newborn period are more prone to intellectual and neurological problems. Because we have to adjust their diet quite significantly, decrease bone mineral density is a problem, so we monitor calcium and vitamin D carefully. And for reasons that we don't totally understand, about 90% of females have effects on their fertility. So that might be that they don't go into puberty as we expect, or they do go into puberty but don't develop regular periods afterwards. However, there have been a number of women with galactosemia that have actually gone on to have healthy pregnancies and healthy babies. And it's quite difficult to predict the impact for an individual girl in early childhood. So there's no cure for galactosemia at this stage, which means that these children and individuals require lifelong management. So the first priority is to exclude all galactose from the diet. So this is one of the true contraindications to breastfeeding. So unfortunately, even if mums go on a lactose-free diet or a dairy-free diet, the human body still produces galactose in breast milk. And so these babies are swapped immediately to either a soy formula or a rice milk formula or an amino acid formula, depending on how unwell they are and parental preference. And they need to then follow this strict diet sort of throughout life. So as they move on to solids, they need to learn how to read labels. Parents need to read labels to avoid hidden sources of galactose in diet. And then we need to supplement calcium and vitamin D if they're missing out on this from their diet. At the time of diagnosis and afterwards, supportive measures are really important. So if these babies are septic or unwell, which is often how they do present if they present clinically, infection needs to be aggressively managed with antibiotics. If they've got liver impairment, which is pretty much part of the course, coagulopathy needs to be managed aggressively. And then as time goes on, speech pathology, important assessment, and early intervention is really important. As is the provision of genetic counselling for families so that they understand whether this is something that's likely to happen again in their family in future pregnancies. And then, of course, these children are linked into the metabolic clinic and we manage them and monitor them long term. So carefully monitoring diet, carefully monitoring development. For the girls, we monitor puberty carefully and might refer off to endocrinology if they need assistance with going into puberty, and managing the bone health carefully as well. I briefly mentioned this is a genetic condition, so I guess it's really important for parents to understand that this is not anything anyone has done wrong. This has been present at birth and there will be no signs during pregnancy. Certainly not caused by mum having too much dairy or anything like that during pregnancy. And the mechanism of inheritance here is what we call autosomal recessive. So each of us carry 2 copies of the GALT gene, and we pass one of these copies on to our children when we have children. And most parents would expect them to be healthy carriers with one functional copy and one non-functional copy of the GALT gene. And if bad luck so happens that both parents pass down their faulty copy, then that child will have galactosemia. And often there's no history in the family, they've never known it before. Some days these parents might choose to access private carrier screening, which might detect this before the baby's born. But in most cases, it's a surprise when they learn this diagnosis. So I thought I might just present a couple of case studies now to talk about how these babies might present clinically and how newborn screening might fit into that to perhaps aim for better outcomes. So the first baby is a baby that was born at term, had a good birth weight of 3,300 grams. Mum had a bit of a challenging life. This was her 4th baby, and she had some previous drug use history, and socially she'd found it quite difficult to get to antenatal care appointments, but had been diagnosed with gestational diabetes, which she was trying to manage with diet. She did attend hospital appropriately for her delivery, and the newborn screen was taken on day 2 of life, but unfortunately it was an inadequate sample, and the hospital had not managed to track down to get a repeat sample collected. So this baby effectively did not get a newborn screen. Over the next couple of weeks, Mum was quite worried about this baby and actually saw 3 different GPs raising her concerns that her baby wasn't feeding well and wasn't gaining weight and seemed distressed. Unfortunately, this baby was never weighed again, and no one appears to have investigated the jaundice either, as far as we can tell from those GP's records. And then at 3 weeks of age, Mum became so worried she actually brought the baby to ED, describing them as grey and not feeding well. And at that stage, they had lost 1 whole kilogram on their birth weight. The baby looked critically unwell, very similar to this photo here, except probably a bit worse colour. Had a capillary refill that well exceeded the safe range, was mottled and had this very loose skin because it had lost so much weight, and then had this quite swollen abdomen. And the markings on this body here are how big the liver had swollen in a baby with galactosemia. I promise that we don't do this to them anymore in the bed, but this is a very good sign of how these babies might present. And so this baby had a lot of tests, including a blood culture, which came back at 1.5 hours positive for E. coli. And that's the fastest, most positive blood culture I've ever seen, suggesting this baby had a very high level of infection. And when we asked the ophthalmology team to examine them, they found these very typical oil drop cataracts in the baby. And these tend to melt away once you put the baby on the right treatment, but could be sight threatening if they weren't recognised and the baby wasn't treated for galactosemia. And so this baby then went on to have a galactoscreen, so testing for that GALT enzyme activity, and theirs was undetectably low, consistent with classical galactosemia. So this was a real missed opportunity. If this baby had perhaps had an adequate newborn screen, and we had known that the newborn screen was abnormal for galactosemia, there might have been a bit more effort put into trying to locate this baby. Mum had certainly been raising concern very appropriately that her baby was unwell. And so it was a real shame that this was a missed opportunity. This baby presented so unwell and had a prolonged ICU admission. But once we made the diagnosis, we followed a standard treatment plan. So this baby was swapped to soy formula. They've gone on to have very careful speech and language monitoring. And because this is a girl, there's planned for careful pubertal monitoring once she gets to the right age. So just to briefly touch on what we actually do for newborn screening for galactosemia, it's just on a dried blood spot Guthrie card, which we talked about in a bit more detail in the following talks, and we measure two things. So we measure the total galactose, which will give us a hint if we've got an enzyme defect in any of these 4 enzymes, because the total galactose will be high. But specifically looking for classical galactosemia as well, we actually measure the enzyme activity of anyone with a high galactose result to see whether there's any evidence of classical galactosemia. And so just one more baby who presented a little bit differently because of the role of newborn screening. So first baby to parents, had an uncomplicated pregnancy. Birth went fairly smoothly. They were discharged home day 2 of life, and the newborn screen was collected appropriately. They had a little bit of mild jaundice that wasn't requiring phototherapy, had a couple of blood tests in the community, and was actually breastfeeding quite well at home and seemed to be quite well at the time that the newborn screening test came back positive and suggesting of galactosemia. So this baby had both a high total galactose and a low GALT enzyme activity. So we were suspicious for classical galactosemia from the start, and recalled this baby by about day 9, got them back into hospital. Unfortunately, they were regional, so the cards had taken a little bit longer to arrive. And this baby came in for an assessment. Baby still looked fairly well, but was a bit jaundiced. There was some derangement of liver function. The sort of liver function tests were up to about 200, so 4 times the upper limit of normal. But what was most concerning is this baby had a quite abnormal clotting studies. So an INR of 3.9, it shows markedly dysfunctional clotting system and places this baby at risk of bleeding. So immediately we stopped breastfeeding for this baby and started them on soy formula. They received 2 units of fresh frozen plasma to try and prevent anything like an intracranial hemorrhage occurring. And the liver function test normalised over the next couple of days. Was carefully investigated for infection, and that galactoscreen test was done, and again was consistent with classical galactosemia. This baby had a much shorter hospital stay. They were discharged home 2 days later, taking soy formula well, and now being followed up in the metabolic clinic, and we're monitoring their speech and development and having ongoing dietetic input to support the parents in looking after this baby that's now transitioned onto solids, which makes it a bit more challenging. And it's doing really well. So there's really clear, I guess, signs that picking these babies up early before they become unwell provides much better outcomes and prevents some of the more catastrophic complications if we can catch them in time. So just a brief summary of the things that I've hopefully managed to convey. The first is that galactosemia is a rare disorder, but we do expect to find a couple a year. So it may be possible that you do come across a baby or 2 in your career. Sometimes they cluster and we get statistical anomalies. And these babies can become very unwell in the first days to week of life. And that the symptoms are usually non-specific until the baby is quite critically unwell. And so there's a good window to try and pick them up before then, because if we can recognise and treat them early before catastrophic complications occur, they're going to do much better long term. And this is where newborn screening comes in, so that we can improve our early detection of these babies before they present clinically. And the treatment of classical galactosemia is to exclude galactose from the diet, so stopping all dairy or mammalian milk feeds and replacing them with appropriate dietary replacements such as soy or rice milk formula and close developmental monitoring. I think that's probably it for me, unless anyone's got any questions that need urgently answering. Otherwise, I might pass on to Dr. Mercy Thomas to talk to us about the screening cards and newborn screening program.
Thank you, Talia. I'll share my slides. Can you see those slides? Oh, good. Yeah, thank you. Thanks, Talia. Good evening, everyone. So in this evening, I'll give you an update on our newborn screening program. So we will review how our program is in terms of performing, in terms of its success, and also we can see some of the opportunities that we can look into to improve our program. And we'll then review the changes, the recent changes that we have made on the newborn screening card and how is that important in terms of applying blood to all the 4 circles of the Guthrie card, especially when we have the galactosemia being implemented and the changes in terms of feeding information that has been incorporated into the Guthrie card. So as we said, we'll just review some of our KPIs. And you can see there is a lot of information on this slide, but I'll go through that one by one. So you can see in the last 3 quarters, we have roughly around 60,000 newborns that we have delivered in Victoria. So the KPIs, it's an expectation from the Department of Health to ensure that at least 95%, that's a minimum of 95% of the first samples should arrive to the VCGS lab within 4 days of sample collection. The positive thing that you can look here is we have collected more than 98% of the samples within the 72 hours. So well done to all the maternity centers and the new NICU centers. And we can see in the first quarter, it was less than 95%, but we are picking up on that delivery within 4 days. And sometimes it's mainly because of the courier service or there is some issue with the postal service, or sometimes people forget to send it to the VCGS lab, but it is our responsibility to check that we have sent that to the lab. So at the same time, you can see that there's another KPI that we look at is, again, the recollection. Sometimes we request for recollection, especially if the samples are not good enough for analysis, or sometimes if there is missing information, or if we need more blood for further analysis. So the recollection, we need to ensure that it is recollected within the 12 days. And you can see the percentage here. We still need to do a lot of work in that area to get that above the 95% where the Department of Health has requested us to follow. The other interesting fact that you can see here is this. The unsuitable sample rate, and ideally it has to be less than 0.5%, but the numbers are like around 0. So around 157 to 180 samples are not up to our standard that we wanted to have. Again, some of the samples are not signed, and there are many reasons people say, mainly because sometimes the parents are not available and we have our own concerns around that. But ideally, we need to make sure that these samples are consented and signed by the parents so that we can proceed with the analysis. Otherwise, again, there is a delay in analyzing these samples. The other interesting fact that we are looking in here is the refusal rates that are increasing. It used to be 0.2%, then it became 0.5, and you can see that in all the quarters, it's 0.7 to 0.8. So this is the statistics of the overall Victorian health centers. But if you look into each of your health centers, you'll see some of the numbers are different. Some you do not have any refusals at all. Some you have at least 3% of the population is refusing. So this is something interesting. We are looking into that to see why why the parents are refusing for screening. Is it because they're not able to understand the importance of the screening process, or is that because they're worried about their data being saved somewhere else and the children's life could be compromised? Some of them have got that anxiety as well. And we see that when we get email requests from the parents asking for their cards back. So this is something to look into that. And when we actually discuss with the family, we need to understand why they are refusing the newborn screening. And you see that from Tally's presentation, that how important to identify these conditions in its early stages, rather than coming to the hospital after 6 months with clinical presentation of complications and things like that. So the other update that we would like to give is, as you see in the previous slide, we used to give report every 3 months. Now onwards, every hospital will get a weekly report to the newborn liaison person, indicating how many samples we received, how many samples we processed, or in case if there are any issues with any of the cards that we received, all this information and the KPIs will be reported back to the newborn liaison person. So this is something that you could track and monitor. So as I said, we have updated the newborn screening card recently, mainly to incorporate the feeding part of the requirement for the galactosemia screening. You see that in the new card, you will see the sex of the babies column have moved up. And also we have more space here for the sticker or the UR stickers or the details to be entered here. And then you also see that the TPN, the breast milk, and the formula options are available. As Tally mentioned earlier, if the child is on breast milk and if there is increased like if there is an issue with the galactose intolerance, they'll be able to identify what sort of screening pathway they should be following. So it is important to tick that boxes, whether it is a TPN the child is on, or whether the child is under solely breast milk, or if it is a mixed feed, ensure that you tick both breast milk and the formula boxes. And if it is a formula only one, it will be great to have some information around what type of formula, because again, there are varying levels of things that you can identify with the type of formula. So there is no such space indicated for that, but if you can write there whether it is S26 or whether it is N95, so whatever the formula that you're giving, if you can document there, that will be helpful as well. The other information you hear is the transfusion or the pre-transfusion column. So these are some of the new things that got added. You will also see that this area has been renamed to relevant history rather than clinical and family history, because often I've seen most of the midwife, they used to ask, do we have to document all the family history in here? It's not related to that, but if the family has got any sort of allergic reaction or galactosemia in the family or the cystic fibrosis in the family, any relevant history that you want to document, that's the area that you can document that information. The other thing you'll notice that at the back of the card, we have simplified the instructions. So you can see the information is listed 1, 2, 3. You ensure that you soak blood from this side until each circle is full, and make sure that you fill all circles with blood. So you can see that number of screening has increased compared to the previous years. So for the lab to facilitate all the screening, we have to ensure that we fill the 4 circles so that they get adequate number of area that they can puncture and take it for analysis. This is not something new, that we all know that we have to air dry the card before we send it via courier or express post, and the details are given here where to send it. So and we know that it has to reach the lab within the 4 days. So often we need to send it within 24 hours, and we need only 4 hours of drying. So the courier service or the postal service can get it to the VCG center within the next day or so. So how do we collect a sample? We have sent out a newsletter recently, and that has got the link to the new video, and also it is available on the VCGS webpage around the good sampling technique. So watch that video in case if you have not seen that video, and that's a courtesy from Royal Women's Hospital. And the key thing or the key message that I want to highlight here is ensuring that we fill out all the 4 circles so that we can facilitate the complete analysis that we require to complete. And the lucky last slide, I'm going to introduce our new newborn screening educator. Holly is there in the panel. We can ask questions as well. So please, in case if you need further education on any of the KPIs that we have mentioned, we will be facilitating education sessions in the new year. Please feel free to reach out, and we are looking at all the KPIs of the hospital to see what are the areas that you are struggling with, and how can we support you to ensure that we are meeting the target that we are required to. So thanks to Holly. Holly has joined in, I think, less than a month. So over to everyone now. Thank you.
Thank you very, very much, Tali and Mercy. That was wonderful, and nice and short and sharp messages. Fantastic. Everyone's online, and also in the background we have Svanitha, who is actually controlling this presentation. So I'd like to thank her also. Now, we do have some questions coming through. If you haven't put your questions in, if you could please add them to the box. Now, I've seen we've got also Dr. Joy Lee online, who is our metabolic trainee pathologist, biochemical genetics, and she's joining us for this. And she has just sent through a text of questions, of a question also that I think she wanted to explore a little bit further. So if I may, I might start with Joy and ask Joy about what you think you would like on the card for about formula. What would you really like to know? Because I think we could all write lots of things about formula on the cards for galactosemia. So what's the key message that you'd like to know about the formula?
Thank you so much, Rhonda. You can hear me well?
Yes.
Yes, thank you. Thank you, everyone, and thank you so much for everyone's attendance as well. I think we are all aware that in terms of formula, there are so many types of formula. Like even with S26, there's S26 Gold, there's an X26. So I think so that it will make it easier, we would like to request if everybody can just, instead of really writing the specific formula, whether to write the formula that is being used is lactose containing, lactose free, or soy formula, because that would really be the most important information that we'd like, whether it's lactose containing or soy formula. Thank you.
Thank you, Joy. Tali, what do you think about Joy's answer there?
I think that really summarizes what is relevant in terms of interpretation. So we know that we're looking for an elevated galactose level with the screening, and that's the pathological problem. And if you're not having a mammalian milk and you're not having galactose in the diet, then you may not trigger the flag unless we know to do second tier testing, because we need to think a bit more carefully about this baby. So it's really helpful if we understand whether this baby is receiving essentially a normal milk formula, in which case the galactose level will give us a good hint about whether there's something there to worry about. Or if they're not receiving formula, then we might need to look more carefully at enzyme function, because it may not be accurate on a galactose level alone if they're not getting galactose in their diet. I guess the other thing there is to be aware that the galactose screen level that we do, which is the galactose enzyme, is actually expressed in red blood cells. So the reason that transfusion box is on the card is we need to know whether we're measuring the baby's red blood cells or someone else's red blood cells, so that we can follow up appropriately babies where we might not have had an accurate card simply because they've had a transfusion. Hopefully that kind of makes sense, why those boxes are on the card and why we care about you filling them in.
Yes. And we really do care about them being filled in. It is really helpful to help differentiate. And I think when we do referrals to RCH Metabolic also, and we do scan the card and refer all of that information across to the team. I might go to Mercy. I see Fiona online has a hand up, and I will come to Fiona to you in a moment. Because I'm not sure how to do the online direct questions, but I have a question for Mercy. And if 3 circles are filled, would that be rejected?
Of course not. We will still continue doing the analysis, but it will be great to have 4. But I understand how hard sometimes to bleed a child. So if we get the 3 full circles, we'll still go ahead with the analysis. But just in case, if we are not able to do all the analysis that are required with the 3 samples, we may request for another one. But we will never reject a card if we got only 3 circles filled. So yeah, go for it, because we do understand how hard it is to bleed, especially when the child has not had a good breastfeeding or any other concerns. Sometimes it's hard to bleed the child. Yeah, totally understandable. But we'll never reject a card because it's only 3. Yeah.
If I may say, we have a policy. We test every card irrespective, and we will test, we have an order of testing as well to because newborn screening is very much about saving lives and saving brains. And so we have the high risk and high frequency tests as our first, if we're running out of sample, and the less frequent ones will be asking for the recollection if we don't have enough. And we test everything, and we actually prioritize the metabolic testing as the first punch that comes out, because it's really the biggest bang for our buck. There is so many different diseases we can pick up there. So, but yep, I think that's enough from me on that. So the next question I think is a bit to Joy as well, and Mercy, but the formula for all babies, if using do you want, there's very little room to write. So I think I'll start with my perspective on this. What we're really interested in is if they're purely formula fed. If they're also receiving breast milk, then we know they've got a lactose diet. And it's the babies that have been totally removed from lactose, and so they've got a totally soy-based diet that we're really interested in, or who are not getting lactose because they're on TPN, because they're the ones that we could miss. Now I'll go around the room to do that as a bit more clarification. I'll start with Mercy there.
I do agree with you, Rhonda. I know it's like very little space you have, but I believe utilize the side space that you have. So tick the box of formula, and then whatever possible information you can write with the limited space that we have on the side. So as Rhonda said, any information is helpful. So that will facilitate the screening, and for further like diagnostic measures, if you have to facilitate, that information will be really helpful. So anything that you can contribute will be helpful for the lab as well. Thank you.
Okay, thank you. Tali, do you want to comment on that at all?
Sure. I mean, I think practically most babies on day 2 or 3 of life are often on are very rarely on no galactose at all in their diet. So it's really just those very rare babies that, for say, family preference or previous experience, decided to start, say, either soy or rice milk formula from birth, that we might not otherwise capture. And the reason that we want to know about them just in a bit more detail is they actually have a different analysis pathway for trying to work out when we might do a recall on their newborn screen. So because their total galactose might not be high if they've never had any galactose exposure. So we need to look more carefully at their enzyme function. So it's really just making our life a bit easier and trying to prevent us accidentally causing any distress to babies that might in fact have a very normal test result, but we just didn't have enough information to make that call. So we perhaps were overly cautious in recalling those babies. And that means that they then get further testing, get brought back into hospital. And obviously that's not very nice in the newborn period if it's unnecessary, but obviously is also essential for those babies where we might be saving their life.
Okay, thank you. And Joy, do you have anything to add on this? I think everyone's covered it, but you might have your own little tidbit here.
I think because of the space, there's actually space at the back as well, if really we need to find some space. And then I think just the most important why we are so concerned about the formula, the ticking of what type of formula, whether they're on TPN, breast milk, or on formula, is because we might miss a patient with galactosemia, which we don't want that to happen, because it might be that the patient was on formula and then we would have no further information. As Tali said, the pathway that we're going to go into in terms of testing will actually be dependent on the information that we're provided with.
Thank you. Now I have some more questions here. I might just give you a warning, Holly. I might throw you in the deep end a little bit so you can talk. Okay, just a warning. Okay, I might have my fun here a little bit. So I've got a question here, which I think is a really good one. And I must admit I hadn't noticed until recently. It was the circles on the back of the cards do not seem to line up from the front to the back. What is the significance or importance of soaking the blood from the back? So there's two questions here. So I'm going to start with the first question, the answer to that. The circles on the cards do not line up from front to back. On our latest version of the cards, they should, and this is thanks to Maggie in the lab who actually picked it up. When we test all our cards, all our new batches of cards, because we make them ourselves, and we actually test them over the ink. So the ink on the cards does not affect our screening for any of our tests, and we're quite confident about that. But the most recent batch of cards, we think we've fixed that problem. So, yep, good spotting, Karen, I'd have to say, because we hadn't spotted it for years until recently. And the second part of the question, what is the significance or importance of soaking the blood from the back? Does anyone on my panel know?
We have to soak it through because when we punch, so we are actually getting a specific sample of the blood spot. So if it did not soak through, then the way we interpret the concentration of the chemicals that we're checking might not actually be what we are getting because the blood was not soaked properly. So there will be no enough sample. So that's why it's very critical to have the sample sort of properly collected and soaked through from front to back.
Yeah. When we actually punch out the blood from the card, we have the patient's, the baby's details at the front, and there is a little camera to make sure we've punched the sample out into the right well.
Is about to close.
Sorry.
Visiting it. That it is now. Thank you for your cooperation.
Okay, you can tell I'm still at work. So we actually have the baby's details at the front, and if the blood is soaked from the back and it's soaked properly, as Joy has said it's needed, we can actually see that the blood is there at the front. That proves it's soaked properly through. And so that's all recorded as part of our traceability process. So that's why we ask for it to happen from the back of the card, because we've got the patient details and we need to see that full soaking through. So it's just a quality exercise from our part. I hope that's helpful, Karen. Mercy and Holly are happy to explain that further when they come out to do education. Okay, so do we need to use the alcohol swipe to clean the baby's foot before collecting the blood? Holly and Mercy for this one.
You want me to go?
If you're ready, yes.
Yeah.
Because I know you're very passionate about this.
Yes, no, definitely. Yes, we do. You just wait, give it a good, 5 seconds or so for it to dry before you puncture. But we're definitely wanting to wipe away any debris, and Mercy, you probably know as well, often changing newborn bubs' mech nappies. Sometimes they like to put their heels in them. So yeah, cleaning the site before you puncture, but just ensuring you're giving enough time for it to dry. Anything else, Mercy?
All good. I think it's a practice. There is difference in practice in many institutions. That's why people are asking this question. And some organization, they don't recommend wiping with alcohol. They said just clean with a like a cotton. They don't use cotton, like a swab or something. Do not have to use an alcohol wipe. because you're not
Yeah.
collecting. Yeah. So it's a practice difference. That's why people are getting confused. Do we really have to use the alcohol wipe to clean it before we take the sample? So I would say follow your hospital protocol, what is recommended, and
Yeah.
that way you are safe to practice in your organization.
Yeah.
And our video does have an alcohol wipe in it as a recommended. The next question I have, what are the I think this is for Tali, what are the clinical conditions you need to know about prior to taking the sample?
I wonder if that's the line on the card that says other relevant history rather than what it might have said previously about family history. So we get a lot of calls as a clinical team where there might be a history of particular diagnosis in the family, such as cystic fibrosis or one of our metabolic conditions. And that can be really helpful for the laboratory if you do document that. So that some of those families actually do want to seek out a confirmed diagnosis or lack thereof on a newborn screen, but also so that we can be more appropriately prepared to follow up those babies clinically when bringing them home, when bringing them back to hospital to recall them. With obviously things like newborn, with transfusions and things like that, we would be very grateful if they're documented appropriately. But the newborn screening is valid for just about everything else. It wouldn't change necessarily the way that the sample is analysed in the laboratory, but can help with interpretation if we get an abnormal result later on.
Thank you.
So if there's anything the family tells you, feel free to write it down and make it our problem for interpretation.
Thanks, Tali, for that. Fiona is online and she did have a hand up. I don't know how to do it live. Fiona, would you be happy to type in your question? And maybe you already have, but I haven't seen it come up. Apologies for that. There is a question here that I might take, and Joy, you might like to join in for this one. And it's, how do you choose total galactose versus GALT activity for newborn screening galactosemia as first line? So we have chosen total galactose as our first tier because we are very committed to harmonisation with our other jurisdictions in Australia and New Zealand, and they all do total galactose as the first tier, and we are quite committed to that process of harmonisation because we think it's the best path forward overall. There are other jurisdictions around the world that actually do it the opposite way, where they do the GALT activity first and then go and do different versions of the assays. So there are different protocols and they are in the literature. The reason we do it, we've set it up the way we have is for consistency between the jurisdictions. Joy, do you have any additional comment there?
I think that's also the information that will be provided. For example, you take formula and it says soy formula, then we know that we cannot rely on the total GAL. So we still would measure that, but we will also do the second tier already. So the GALT enzyme activity, because we know that we can miss a patient with classical galactosemia on soy formula. So that's again sort of another example why it's so important to have the proper information on the type of formula. And also, for example, with Tali's emphasis on the blood transfusion. So we know as well that with the blood transfusion that can affect our GALT activity. So all this information would be factored in terms of the test that we're going to do, whether one first, total GALT first, or both at the same time, or so that's what we are doing. But as of now, right, Rhonda, we're still trying to establish sort of how we're going to do our cutoffs and so on.
Yeah, So we've actually been doing sorry, Tartly. I'm sorry. I'll jump to you. We've actually been doing a comparison of what the other labs are doing in Australia and New Zealand via an email. So we have our cutoff at the moment, but we've now started a process to look at what others are doing and whether we can go through with the HGSA a bit of a harmonisation process of those cutoffs as well. So because there does seem to be some differences between the other groups. So that's a work in progress, as everything is. Tali, please go ahead.
I think I was just going to make the comment that if we think about what we're detecting with an elevated total galactose versus a GALT enzyme activity, that GALT enzyme will specifically look for the classical galactosemia, but we can actually see an elevated galactose level in those other forms of galactosemia as well. So it gives us an opportunity to not just pick up classical galactosemia, but say a galactokinase deficiency or an epimerase deficiency as well, which is worth knowing about, but isn't the primary target.
Yeah, thank you. Yes, good point. Sorry,
So more bang for your buck.
Yeah. So I think given our timing, we've got 4 minutes until the end of the session, and I think I might go to this question as our last question. And Holly and Mercy, be warned again.
Yep.
To both of you. So this is about blood collection again. So what about those babies who've had various blood samples taken from the heels? So I think we're talking special care nurseries, NICUs here, e.g. for hypoglycemia, jaundice. An alcohol swab to clean the site would be quite painful and I would think contraindicated. My first scenario would be try and do the newborn screen when you're doing another blood collection, so you wouldn't actually have additional heel pricks if you can sort that out.
Yeah, I think the question is again related to because it can be painful for the baby when you wipe it with an alcohol swab for cleaning. So that's why sometimes it's recommended you can utilize sterile water to clean the site, and the site cleaning is again recommended if it is soiled. So it is that's what it is confusing now. There are varying practices and varying recommendations. So it does require cleaning if it is visibly soiled, and if a patient has got multiple puncture sites already. I think the hospitals, when it comes to capillary blood collection, it often recommends with especially the NICU that I worked, we use sterile water to clean because we do not want to hurt the baby again. So that's why the practice is different. But whatever the hospital recommends, based on that, follow the protocol. That's what I would recommend.
Okay, thank you. I'd like to thank Holly for joining, and Mercy for joining, for Joy for joining, and especially to Tali for joining. We're very lucky to have you here, Tali, and thank you. I'd also like to just do a couple of shout outs, please. I'd like to shout out to Doris and Kai, who have been the in-lab people doing the hard yards of all the method validation and verification for galactosemia. And that they have done a wonderful job. And we have a fantastic team in the newborn screening lab, but it's not just the newborn screening lab, it's the team. The teamwork is actually the newborn screening program for all of Victoria, and everyone who participates in that, from collecting the sample, consenting the parents first before collecting the sample, making sure the sample is couriered to us through to the lab components, and then importantly, we get the referrals, and for galactosemia, it's to the RCH metabolic medicine team who go and find that baby and bring them in for follow-up testing. And it's just a wonderful program for babies of Victoria and babies of Australia. And so I really thank everyone for being here. If you have any questions, we are here at VCGS and we can take questions. There is a VCGS email address, and I think you have If you're a midwife, you already have the newborn screening email address, and we're happy to answer any questions. So please do send questions through if you have them. We have two fantastic educators, Holly and Mercy, who are also very happy to come out and do education at the various hospitals and also the private midwifery services. Thanks, Winesha, also, and thanks everyone online for joining in the evening during your dinner time, I know, and it's been a pleasure being here, and we're really excited to be offering galactosemia. Thanks a lot. Bye.